Hi, so this is the LTC Applied Practice assignment, and for some of my thoughts on becoming an LTC dietitian and the challenges you will face, I feel like it is a lot of responsibility because you are working with a lot of nutritionally high risk patients, such as patients that are malnourished, or it could be more difficult to do an adequate nutritional assessment on them. Because a lot of them will have mild cognitive impairment or Alzheimer's disease, and also they're at high risk because a lot of them will have either pressure ulcers or wounds, and you do have to frequently monitor them and be on top of it. But I do feel like that aspect of it I would like. Some aspects that would be challenging for me would be having to witness the wounds or the pressure ulcers, because I can get kind of like a queasy sick feeling when I see things like blood, and I have never actually witnessed one myself, so I don't know how I would react to it, but that would be one concern that I would have. And also, I feel like another challenge would be making sure that you can deal with maybe some sad things that you'll see, like the neglect that some of the residents would experience from their family members or relatives. Even, once you establish rapport with some of the residents and clients that you're with, if something bad happened to them. So just being able to cope with that and making sure that you are emotionally stable enough to do that. Also, the frequent weight monitoring and making sure that you're getting the actual weight of the patient, and charting is another a challenge or responsibility that the dietitian would have. So that's my thoughts on that. So with the patient that we're discussing, her name is June Anderson. She is a female resident of the Senior Care Center and is an 85-year-old. She recently fell and had a hip fracture. She did go through hip surgery and is out and is going through the recovery process. She does have depression because has showing signs of depression, as her husband has recently passed away 6 months ago. And with this, depression has become kind of signs of social withdrawal, and with one of these things, she's had a decreased appetite. So that is one reason why I'm seeing the patient today. Some of her anthropometrics are she is 167.64 centimeters. Her actual body weight is 54.5 kilograms. Her ideal body weight is 59 kilograms, and her ideal body weight percentage is 92%, which is still within the 10% plus or minus range, but the patient has experienced an 8 kilogram weight loss since her husband's passing, which is 15% of her usual body weight that she's had unintentional weight loss, and this is a criteria for malnutrition. Her BMI is 19.39. For her nutrition assessment, we've realized that she does have poor appetite. She is showing going through some psychological stress, and it is important to note that she is about to start PT, which will increase her exercise and moving her around more. Her usual bedtime is 9 p.m. She wakes up at 8 a.m. And after doing the mini nutritional assessment, which is a common screening tool used for geriatric patients greater than 65 years of age, she did get a score of 1, so she is malnourished. My PES statement is severe chronic malnutrition related to poor appetite and social withdrawal as evidenced by greater than 10% unintentional weight loss. Hers was 15% within 6 months, and less than or equal to 75% of estimated energy requirement for greater than 1 month, as evidenced by her stating her poor appetite in the assessment. So when I calculated her needs, I did it based on 30 kcals per kilogram, which equaled 1,635 calories that she needs in a day. I got her grams of protein as 65 grams, and I got this calculation by doing 1.0 to 1.2 grams per kilogram, which is it's good to use this, and they've identified this through the PROSTAT study on older adult patients. So with the nutrition problems would be her decreased appetite, the malnutrition, and she's at risk for osteoporosis. So for her interventions, initially you would recommend a high protein, high calorie diet through the supplements. And you would get her food preferences. And it wasn't very clear in the chart, but I'm guessing that the senior center that she's at and that I'm working at is a long-term care facility. But if not, I would do a coordination of care with the social worker and make sure after she leaves the center that she looks into joining a long-term care facility. I would also recommend the patient utilizing the congregate meal service that is offered in the Older Americans Act, just to help the client build some community and increase her social interaction. This can help with her depression, and a lot of the times, when you're depressed, you'll either eat less or eat more. In this case, I feel as though the patient her appetite is being affected by this depression in a negative way. So I feel like that this could help her intake and would be part of my intervention. So the Minnesota Board of Aging is what I would use through their senior nutrition programs. And I would just encourage her to start joining potlucks at the senior center just to build some community for the patient and I didn't state this, but in her social history, her children are out of state, so they're not really able to help assist her in increasing her health and quality of life right now. As you're going through the assignments, you realize that she's not enjoying the supplements, she's not increasing her oral intake, so you do get to the patient needs enteral feeding. I recommend using the delivery method of NG tube because of the doctor's referral, and using cyclic enteral nutrition and nocturnal feeding for 10 hours. And I recommended this because she does sleep on average of 11 hours, stated in the as she stated. And then I would use this cyclic I would use the pump-assisted continuous feedings nocturnally so that the patient is able to maintain her quality of life and still get those meal times so that she can increase her social interactions and still feel like more normal. I feel like this would be necessary for her in her state, in her psychological state right now. It also allows for ambulation since she is doing PT for at least 3 hours a day. And also I recommended the nocturnal cyclic feedings because it's easy to transition back to oral nutrition, and you can kind of, use this method as a supplementation for her inadequate intake and adjust it based on her intake. So in this instance, they said you need to, have her get all her needs in the tube feeding. So I would suggest Parative through NGT tube at 125 milliliters per hour for 10 hours with 64 milliliters per hour of free water flushes if she's also not getting adequate hydration throughout the day. And this would provide 1,638 calories, 84 grams of protein, which is high, but I feel like this is okay since she is malnourished and is recovering from hip surgery. And it also provides 1,635 milliliters of water with the water flushes included. So, I got to the enteral feedings because the patient did not continue to not meet the estimated needs. And also, lastly, in my intervention, I included that the patient could benefit from a calcium and vitamin D supplementation since she has had fractures and is at risk for osteoporosis. So that's the end of this recording. Thank you.